how do you can see in all the photos what we say vital signs and assessment? How do you do that with the we check for the BP? Why do we use thermal scanners? You think it gives accurate results? Thermal scanners, most trending kind of no. Yes, yes. So why did thermal scanners come into market? What is the main cause? Yeah, for screening. Okay. So, but yeah. So basically, it's the main criteria was to just prevent spread of infection and screening. Yeah, nice. Basically, it was done to just do the what we call a distance kind of a thing from a patient, so that there is no kind of infection that can be spread. So routine monitoring and framework. We are not in that. Yes, good. So routine monitoring and care framework for such kind of a patients, as you can see for COVID-19. So how do you disposition a patient? Okay, you can just go through this chart. Vitals, if you check for a temperature, okay, you check for oxygen saturation 2, respiratory rate, heart rate, and blood pressure. Okay, the three categories you see: mild to moderate, and then severe and critical. Patient disposition is basically mild to moderate. You can keep the patient at home. Okay, moderate, second category, you can keep a patient in inpatient ward. Okay, in the hospital. And severe, high dependency or intensive care unit, HDU as we say, and critical, obviously ICU. So you think like if we manage a patient in HDUs, is it worth it? We can manage a patient in ICUs like we manage in like can we manage a patient in HDUs if like we manage in ICUs? You think that the high dependency unit, is the management the same like the ICU setups? Yes or no? You must be knowing. You understand with the high dependency unit, right? Can anyone tell me that? Is the management in HDU the same as in ICUs? Yes or no? I guess no one is answering. Okay. So, what I'll say is the HDUs also they have the same facilities. It's just a step down kind of intensive care unit only, and the management is the same only. It is basically dependent if there are the shortage of beds in the ICU setup, so we shift the patient to the HDU and manage well. And if the severity goes up and down for any kind of a patient, that can be shifted along. Okay, so assessment measures you see that is based on physical examination, mental status, and intake and output for the patient. Okay, so mild cases they require minimum management. Okay, and moderate they require everyday assessment. For you can see for an inpatient ward you do a 6 to 8 hour check for every patient. Okay, and severe is you do like on your shifts. Okay, intermittent kind of a patient 2 to 4 hours, and for a very severe like we do every 4 hours. Okay, and for very critical we do every 1 hour. So you should remember this. Okay, so if I come to the management part, so antibiotics should not be prescribed. Okay, unless there is an explicit clinical suspicion of a bacterial infection. Okay. In addition to few patients with COVID-19 experience a secondary bacterial infection. What do you think those bacterial infections are? Can anyone tell me? The bacterial infections that you have must be knowing the patients suffer along with COVID-19.
So I request all the attendees, I'm just repeating the question again. What are the bacterial infections you have found with the patient suffering from COVID? Please write it down in the chat box. We have one answers from Shobit, tuberculosis, and Pranita, hospital-acquired infections in case of long hospital stay.
Okay.
And Nodal, Klebsiella.
Tell me one that famous that you heard that suffered, the patient suffered, the most famous one. Yeah.
We have answer from Nirupama, pneumonia.
Yes. Klebsiella, pneumonia, hospital acquired are, it's very common kind of a thing. And any other than any bacterial? Famous one? Black. Okay, man. Black.
I think there might be a typing mistake.
Yeah.
It might be a black fungus.
Yes. So mucor was the most like what do you call the most suffering that people have seen that came into the picture. So how do you treat such symptoms for the patient that has suffered? So we will start with the like on moderate cases. Okay, how do you treat? I say fever of see a patient is suffering, what we say, a patient comes to you with a fever of 102 degrees Fahrenheit and multiple episodes of vomiting, BP 90/60, pulse is 110. How do you manage this patient? BP is 90/60, pulse is 110, fever 102, and COVID-19 positive.
We have an answer from Noral as a septic shock.
Okay. Nurul, we don't have a ABG machine here. How do you manage the patient?
We have a couple of answers, doctor, from Dr. Riddhi, symptomatic treatment, fluids, antibiotics.
Good. The patient is suffering from vomitings. No one gave antiemetic. Very bad. Very bad. PCM. Okay. So one question to everyone. Antipyretic. Which antiemetic will you give? Name one. Any good antipyretic? MSET, ondansetron. MSET, ondan. So okay, the both are fine. MSET and ondansetron. We usually give what we call MSET here. Okay, how much? 2 will be fine. MSET 2, MSET 4, or MSET 8. 4. Okay, 4. I said multiple episodes of vomiting. 4 or 8? Yes, 8. Yes, 8 and 4 we can give, and later if 4 is not working, so okay, 1 we gave MSET 4 mg to a patient, and patient is still throwing out. You gave all those PCM and fluids. Then still person is throwing up. What you gonna do? You give MSET 8 mg. The next step. which anti-emetic or any drug of your choice you're gonna give. Okay, the BP has come to 100 by 80, and the still patient is throwing up. Yeah, pantoprazole is fine. I ignored pantoprazole. Okay, Dr. Ridhi, very nice. Metoclopramide. Perinom, you must be knowing by the name. Okay. So why do we avoid perinom in patients in hospital setups? Can anyone tell me that? Why do we avoid that? We give and MSET or Onden, we prefer that. Why do we avoid metoclopramide? What is the one adverse effect you know? Any good adverse effect? Yes, very nice. CNS depression, very nice. Yes, Dr. Krishan, very nice. It is due to extra pyramidal symptoms. Okay, it causes extra pyramidal symptoms, and that will just scare you out there in the hospital setup, and you'll just get more panicked to see such kind of a patient going all like howling out there. So we managed the fever for the patient, we gave antiemetics, we managed the BP for the patient. Okay, your patient is in the emergency. Any others? What you're gonna give for the shortness of breath? What you're gonna give to the patient? Any which inhalational corticosteroid? Nebs, okay. Nebulization with Duolin. Okay, just type the so salbutamol, Budicort or Foracort. Is Budicort good or Foracort? Why Foracort and why Budicort? Basically, what is the like? Why do we use Budicort? What is the main advantage? Which thing that is used? The Budicort. Why do we use Budicort? Yeah, it is. That is one thing. We can give, see, the what we Dr. Pranita, basically I understand, like it's a good answer you've given. It's basically freely available in all setups, even if you see Floracort is also high efficacy, comparatively good results for that. Bronchodilation is fine. Along with this Budicort, what you gonna give? Can we give to a patient when ipratropium for such patient? Can we give ipratropium to a patient of such kind? Yes or no? Ipravent, you must be heard. Can we give? Yes. But I guess you forgot the pulse rate was 115. It has not yet come down. Can we give then? Can you give such patient? Or a person with a pulse rate of 115? See, that's what I'm telling you. You should always be all ears, knowing, asking me, like, you should ask rather than answering. You should ask me what is the vital for the patient, what is the BP. You can ask me to repeat. Okay, good. Dr. Ravi, very nice. It will increase, obviously. Yes, it will. So, what are you gonna give to the patient? Can we give levosalbutamol to the patient? Yes. Yes. Okay. So you have managed one patient today. So you managed it with inhalational. Now, what kind of injectable you're going to give to the patient? Can you add on with any antibiotics? Suggest one good antibiotic to me. I give to the patient. Peptas. Okay. Dr. Nurul, do you know the patient's you didn't send any kind of samples for the patient. How do you give peptas? You know how what is the kidney status for the patient? Amoxicillin. Okay, yes. Any other guess? Fine. Peptas is basically that was run in a government setup, so on a flow. They were giving 1 gram TDS. Cephalosporins, good. Ciplox, meropenem. Why meropenem? Why did you go to directly to a higher antibiotic in one go? Why not I start with the ceftriaxone, sulbactam, or I give cefuroxim? Can I give cefuroxim to this patient? Plain cefuroxim or cefuroxim with sulbactam or cefuroxim with clavonic acid? Can it be given? See, primarily, always remember, it is nosocomial, they can be. Okay. See, I suggest you is always, that is what I was telling you again, and it ask me what is the kidney status for the patient, what are the labs for the patient. Okay. If you ask, you grow more. Okay. Always remember, always ask. Like more the questions, more is your clarifications. Otherwise you will be like you're just, if I'm asking you, just answering directly to thing. Just don't do that. Always ask me what is the status for the patient, how is it patient right now. See, if you ask, always bother your seniors when you are standing along with your senior, always keep on asking them if the patient is improving, also if the patient is deteriorating, also always ask them, what do you think the status for the patient, what are we going to do next, how are we going to do next, and always note it down. That will improvise you more and more. Okay. Just don't beat the bush. Like always don't say ki, yes, if I ask for an antibiotic, first you should know what is the kidney status. You should know how the patient has reported. Did no one ask for any comorbidities for the patient? No one. Okay. So always be very specific for any patient that come to you, even if that is a young adult also. Always ask for a past history. Always ask for any medications, everything. Okay. Usually we ask, like we ask everyone ki, do you have any BP or sugar issues, like the basic question we ask. Okay. So what we say, if a person has come with the shortness of breath and he works in a what we call any factory of if might be the person is suffering from any occupational hazard. Okay. Do we consider a patient is suffering from COVID? Obviously not. So you should be very specific. More the question that should arise in your brain, so that will define the patient more well, and you can make a diagnose and even put a patient to a treatment on a safer side and a more efficient side. Okay. So you can see the interventions that has been used for you see the chart, you understand it well, where there is a recommendation and where the recommendation is not. Okay. Ivermectin, hydro. So like, you think what is the role of ivermectin? Can anyone tell me? Ivermectin role? How do you, what does the ivermectin role? Are you giving your patients ivermectin? Did you give your patients ivermectin post second wave? Everyone is like, I think, vaccinated as now. Everyone, yes. 3 doses. I guess everyone is vaccinated. Okay. So, as I told you, when to refer to the hospital, severe critical cases, moderate to risk, mild to moderate cases, patient with chest pain, okay, difficulty breathing, confusion or altered mental status, loss of speech or mobility, Okay. Any other emergency signs you see? Obstructed or absent breathing, severe respiratory. Okay, a person comes to you with a absent breathing. Okay, and he stopped breathing like just like 2 minutes back. What are you gonna do to a patient? COVID positive patient. What are you gonna do? Patient comes to you and absent breathing 2 minutes back, COVID positive. What is the primary thing you're gonna do? First thing, CPR. Yes. Which what kind of a CPR? See, like ivermectin, it was earlier included in the data, like what we call regimen, medicine regimen, in like what we got from the government. Right now, it's been excluded. Uh, so not efficient. See, everything is like what we call. Everyone knows that the new researches have been going again and again and again, but it does not show any kind of decrease in the mortality for the patients. What we see in COVID, it was just like made up, what we call a government, and doctors said ki it should be added to the dose regimen. So but now it has been excluded, and just a symptomatic management. Doxycycline was included, you must be knowing, and it has shown efficient results in this. Okay. But in what we say, if you go with the meta-analysis for this, the ivermectin, it has shown result in least cases, what you say, 44 cases out of 100, not much of it. So CPR you gave to a patient, that is good. Do you intubate the patient? You give intubation? Yes. So you intubated the patient. Okay. You put it on a ventilator, you shift the patient. Okay. So you manage the patient today. Okay. So what do you get to conclude on this? My topic for today is this: screening and triaging of the patient with COVID-19, identify the best plan, monitor and follow up the patient at home, or identification of the emergency sign or the clinical deterioration. Okay. So see, what that is what the main thing that I told on the beginning of this program only, that every day they are changing rules, they are changing protocols for this. Can anyone tell which is the new strain that has come into origin for the COVID-19? B7. Okay. So what do you think? What is the how it has affected people? What are its side effects and all? BF7, Omicron. Any case reported in India? Where is the case reported? The first case that was reported in India? Anyone? Gujarat, yes. Yeah, you people are aware. It's good. Other than medicine, you are also into. Yeah, today, like everything is active. Instagram, Facebook, everyone gets to know what is happening where. So good.